So when we are treatment planning, sometimes we aim too high, sometimes we aim too low, and sometimes we aim too, means I don't know why we are targeting this goal. So let's talk through a couple examples of this. So sometimes we aim too high. We have a client who's 3 years old. We have not mastered simple related 2-step directions, but we have a treatment plan that has a goal of 3-step directions in it. So if we look at our VB map, we see that, at level 2, on point 8, we're maybe starting to do 10 specific motor actions on command, and we're following maybe 52 component noun verbs. But then we know from our ages and stages and our CDC that it's not until 42 months that we are doing unrelated 3-step directions. And so probably for this particular kiddo, we are lacking the prerequisite skills. We're just not quite ready to be there. So keep in mind that child development piece. What are other kids doing? Just because maybe I've mastered 2-8 and 2M on my VB map doesn't mean I'm ready to move on to those 3-step directions. And people might get a little mad in the audience, and that's okay. I ruffle feathers. I'm a feather ruffler. I'll get a t-shirt. We're still aiming too high. I see this a lot in centers, especially where we have circle time, doing some kind of group-based instruction, and we have some goals, because again, it's on the VB map. I get it. I get where people have come to get to this goal, where level 2-9 is they're going to sit in a small group for 5 minutes without disruptive behaviors or attempting to leave the group. But then at 2.10, we're sitting there for 10 minutes. We're attending to the teacher or materials for 50% of the period. And then we're responding to 5 SDs. So I'll see that first goal in a treatment plan that they're going to sit in a group for 5 minutes without getting up and without causing problems. But I'll see that goal in a treatment plan for 6 months. And that's the only thing that they're working on. So my first question that I ask you to answer yourself is, just because your client will tolerate sitting there without challenging behavior, what kind of return of investment are we doing? Like, what are we getting out of this by just sitting there? Is it really that they're 3.5 years old, mom and dad want them to go to preschool next year, there's a struggle for them, we have all these other great skills, we just can't sit still long enough, right? Strategy, we want to run around. What's the deal? Do we really have those prerequisite skills? Because I'm telling you, in order to be successful, to be able to do that material for 50% of the time, to respond to those 5 SDs, do we have a generalized imitative repertoire? Can we follow the behavior of adults and peers without prompts? Can we respond in core responding? Do we raise our hand? What are those kind of skills that I need to be able to do to be successful in a group environment? And I don't think providers are always asking themselves that question. They just see their age and they say, hey, seems like we should be working on this, because at some point they will go to preschool. Yeah, hopefully they will. But again, what are we getting out of this? And do we really have their prerequisite skills? So again, sorry, not sorry if I've ruffled your feathers. I'm hoping that everyone's thinking about this. Tell your friends. Sometimes we aim too low. I had a treatment plan I was reviewing, and caregivers, under their caregiver concerns, indicated they really wanted their kiddo to stop eating with just their hands. They're 4 years old. They wanted them to use utensils, fork and spoon. But then when I looked in the rest of the plan, I didn't see that in any part of the goal. So I sat down with the provider and I asked, why are we not targeting that? I was thinking maybe there was some kind of muscle tone issue, like maybe we had a comorbidity of cerebral palsy. Maybe we need to get OT involved for some adaptive equipment. I just wasn't quite sure what the issue was. And then they told me that the kid wasn't old enough because he's only 4. I said, that's interesting, because and we start looking at child development, we know that we can start using a spoon to scoop food by about 18 months old. We can use a fork to pick up food at 30 months old. At age 4, be able to say, hey, we can be scooping and stabbing easy foods with and no idea. They didn't have a lot of experience with typical kids. They'd only for a short time, and just had zero idea that this was something that was feasible at this time. So if you are using, I know not everyone uses this supplemental checklist. I really encourage you to do that. That will force you to kind of go back and engage with that child development. And then I say sometimes we aim to, why are we targeting this? So I reviewed a treatment plan. A client was 10 years old. They were in school full time, and he was having some limited focus care in home after school. On the assessment, he was unable to identify community. So the clinician opted to add this goal to the treatment plan. But I also noticed that the client was also not able to brush their own teeth or wash their hands independently. And I said, why on earth are we targeting community helpers when this kiddo can't get their own needs met? And again, I didn't really think about it like that. So I encourage you, again, stay away from just shading in the grid. I get it. I get the desire. I get the drive from just shading in the grid, and think about what is going to be if I only have these next 6 months, because maybe I will. Kids 10, we're in focus care. We should be titrating hours, even school time. Like at some point, insurance company is going to say no more. What's going to get them further in their life? Being able to brush their own teeth so that we're not getting cavities and having to go to the dentist all the time, and wash their hands by themselves, and community helpers. I would argue the teeth and the hand washing would be my priority. Okay. So yes, make sure that desire is not coming from, or the motivation is not stemming from your desire to fill in the grid box. All right. So again, just a reminder, these are all the things we should be considering when we are designing care. I know we're almost out of time, so I'm going to quickly go through challenging behavior, because that's really important from a child development standpoint too. Guess what? Kids tantrum, like a lot. Have you met a 2-year-old? Like, they're monsters. My best friend has a 2.5-year-old who she lovingly calls Captain Destructo, because he is the sweetest little dude. But man, when he gets mad, he is mad, and he's going to let you know all about it. How dare you give me the blue cup when I wanted the red cup? And now that you've washed the blue cup because it was in the dishwasher, that is no longer a valid choice. I now need orange, and I don't care if you own an orange cup. I need an orange cup, and I need it yesterday. So kids tantrum. But I see mastery criteria that looks like this. Client who's age 3 will have 1 instance of tantrum behavior for 4 consecutive weeks. Yes, I'm going to show you a resource for shows the readiness skills for, let me come back to that one that we're going to talk about. Let me show you some resources for typical tantrum behavior here in a minute. But we have an instance of tantrum behavior for 4 consecutive weeks. We're going to have a 5-year-old with 0 instances of tantrum behavior for 3 consecutive months. We're going to have a kid who's 4 who have 0 instances of tantrum behavior for 6 consecutive months. Like, please come to my house. Like, please come to my house, because there is no way under the sun that's ever going to happen. Typical kiddos, never mind a kiddo with a disability. Guess what? This is really what we see in typical child development. Times per day is our first row across there. So 3-year-olds are on average having 2.5 tantrums a day, or 6.1 tantrums per week. To 15 minutes, homies. So I will see duration of like tantrum of no more than 30 seconds. Like, are you kidding? Like, it takes me 30 seconds just to get myself mad enough to get into the tantrum. I'm not going to be resolved in 30 seconds. Okay. 4-year-olds are still having 1.9. 5-year-olds are still having them at least once a day, right? Unfortunately, I don't have data from the literature in terms of times per week or duration for the 5, 6, and 7. This is unfortunately an area of research that there is like a dearth in terms of resources, but it's coming. I'm hoping there will be more. And there is a handout for this too that you guys can download as well. And that's on, the citations are on the download. So you can see that. Then let's talk about compliance. So I see master criteria like this. Client will initiate a task within 15 seconds. I'm sorry, unless like someone in my house is bleeding or there's a fire, I'm not initiating a task from someone else who said to me to do something in 15 seconds. Or the client's going to comply with instructions 100 opportunity. So our survey says actually this is what typical compliance look like at 2, 3, 4, 5, and 6 years old. It also looks at their across activities. Snack had a pretty good compliance rate, right? So you can see across activities that may vary. And just real quickly, because I know we're almost at time, 100% compliance is not always a safe goal. We do not want kiddos to be compliant with everything that adult says all the time. It's very scary to think about all the ways in which adults can be abusive towards children. Not want just blindly follow whatever direction an adult tells them to do. Come with me in the bathroom and take off your pants. I would never want a kid to be compliant with that, right? So teaching 100% compliance is not safe to do. So please keep that in mind when you're setting your mastery criterion. And again, this will be something you guys get with the downloads. But even the best laid plans can fail.